Good morning. Welcome to our pearls and discussions after cardiovascular grand rounds on March 2nd. Our speaker this morning, as you'll see, is Dr. Mehta from the NHLBI, and I did do more formal introductions a little earlier. But Nehal just gave a spectacular talk on cardiovascular risk stratification, really giving us unique insights on using biology, imaging, and really using psoriatic disease as a marker, if you will, as a model to understand atherosclerosis. Really cool stuff. So Nehal, absolutely incredible talk. So tell me a little bit about, why use psoriasis as a model for atherosclerosis?
I think the first and most important piece is whenever you're studying a disease state that you are interested in cardiovascular disease, you want to see that that disease state actually has more cardiovascular disease. So in 2006, we discovered that psoriasis accelerates the first risk for heart attack by about 55%. So we started with a common disease that we knew has inflammation because we can see the inflammation on the skin, and it had this upregulated amount of prevalent heart attack and stroke.
Got you. And so, the journey that you just described to us, and I know you hit the highlights because you wanted to focus on aspects of cardiovascular disease, is unbelievable. Just unraveling the pathophysiology of psoriasis as it informs the plaque and plaque progression. You talked about the shift in the cholesterol molecules to the right. Tell us a little bit about the two or three key aspects of psoriatic phenotyping that reflects that higher prevalence and higher incident risk of cardiovascular disease.
The talk focused on really three key elements, Dr. Samadi, and I think that the first one is systemic inflammation. It's long been known that those who have a latent amount of heightened systemic inflammation, whether it be periodontal disease, bowel disease, joint disease, that there's a heightened risk for developing cardiometabolic disorders. So that's first. Systemic inflammation is rampant. The second piece is that we believe that the systemic inflammation is tied very closely together to retarding the function of HDL. So we see this constipation of cholesterol within the system. And that dyslipidemia, as we describe it, is driving all of the diseases that we are seeing as comorbidities in psoriasis. And then third, besides the systemic inflammation and dyslipidemia, there's this predisposition to obesity, but it's not just generalized obesity, it's that visceral adiposity. So our recent paper in JCI Insight showed that when you're inflamed over time without it being treated, you expand out your visceral adiposity component. So I think it's three things. It's systemic inflammation. It's this idea of this metabolic disturbance of HDL dysfunction and this obesity. And what those are all doing is they're allowing this non-calcified plaque to start very early in life because of the endothelial cell inflammation.
Incredible, yeah. So it's interesting, you distill the dyslipidemias and you call it essentially HDLopathy, right? There's an issue with HDL, with the scavenging and removal of cholesterol from the body through the liver. Do you feel that, at least in psoriasis, the primary pathology with respect to the dyslipidemias resides in the HDL component, not the increased generation of the low density?
The low density. So I think, Dr. Samadi, I think it's a combination of both. I do think that there's this, when you have systemic inflammation, the liver itself responds and is a little bit curious. The liver first says, wait, is the inflammation because I'm infected? And do I need to then dump out more sugar so I'll become insulin resistant? Is the liver also seeing that I don't need to make good things like ApoA, so I'm going to just stop making ApoA and save it for things like adrenaline and other proteins that need, so building. So that shift from one to the other, I think, allows us to know that the ApoA reduction And do they make more LDL? We haven't seen that. In most of our chronic inflammatory populations, we see this increase in triglyceridemia, this mildly increased LDL, but this very suppressed HDL. So I'm changing that paradigm and saying, look, it's not just that there's too much LDL that's being either made or consumed, but it's also that it's not being removed. And focusing on both sides of it has actually shown some very promising 4-year data.
Yeah, fascinating and really, really well illustrated for us. So when you think about the journey as far as lipid therapies that we've taken over the years, there was a whole push about almost a decade ago on focusing on raising HDL. And as we learn more from people like yourself and others, we understand that maybe even going upstream from that, in the case of psoriasis particularly, but ultimately potentially in overall atherosclerosis, and targeting inflammation itself with some of the biologics or other sort of easier tolerated anti-inflammatory drugs is the way to go. I mean, as you've discussed, statins are here to stay. HDL therapies, specific HDL therapies, have had their moments in the limelight, if you will. And now, as I understand it, you think we're really moving towards a field of anti-inflammatory therapy for atherosclerosis.
We are. And I think that the most important part of our talk that I found demonstrated that the audience realized that we're at a sixth risk factor type of an approach where we can keep treating the statins or keep using the statins and keep treating the lipids, but there's clearly a residual risk that we are missing, and it's probably a combination of metabolic inflammatory risk. So I do think that we need to remember that it's not just the ApoB, ApoA shift. It's not just this idea of treating this primary source, but knowing that treating inflammation may impact other comorbidities is important as well, that diabetes risks goes down. And so I think we're at a point where we need to make this a cornerstone of our therapy, and we're getting there. I want people to know that it took, if you think of the first 4S study or WASCOPS, we're talking, we're all accepting the statin truth, but it took 40, 50 years to get us there. So I think it'll take time. Just real quick, in terms of the HDL raising therapies, they did it wrong. They were looking at HDL levels to say whether or not the HDL therapies are working, and that was a complete error on the part of the people designing those studies. In fact, when you look back at the AIM-HIGH study and you look at those on niacin that improved their HDL cholesterol efflux, they actually did see a benefit for events in that study. So you need to actually get your HDL more functional, not just get more of it. In fact, some people make a lot of non-functional HDL, so it looks great, but in reality, it doesn't work. So I think that the HDL raising field took a hit, but it still doesn't mean that I don't think that there's something very important about knowing that HDL works.
Got it. Okay, so in the last few minutes, let's kind of pivot and focus on coronary phenotyping. We understand, based on your talk, some of the biology, some of the complexity of the vascular pathways and the biological pathways. It's almost akin to understanding heart failure therapies, right? We started out with the renin-angiotensin system and the adrenergic and all these other pathways. So, biology is complex, and you're helping us understand atherosclerosis. So let's think about practical management of patients with, secondary prevention, known coronary disease. Let me give you, just throw out an example. So you do have a 44-year-old lady, you presented one in your talk, but let's say that doesn't have psoriatic arthritis, but does have the phenotype of the metabolic syndrome, and maybe had some shortness of breath on exertion, the BMI is high, there's a family history, and they have hypertension, central obesity, all the phenotype we know. As a clinician, after taking the history, walk us through how you think about those patients. Do you use the Framingham risk score? Do you use imaging to stratify that patient? How do you take that on?
That's a great question, and I will walk you through step by step what we do, because what I've learned over now 10 years of clinic therapies with these people and these patients is that the first thing that I do is I will start with defining why they have systemic inflammation. So I'll look at their psoriasis and I'll say, how much psoriasis do you have? How long have you had it? And where does it come? And how bad does it,
So Nehal, what about if the patient does not have psoriasis? Yeah,
Oh,
yeah, we're talking about a non-psoriatic patient.
I'm so sorry. So if the patient does not have psoriatic diseases, it's a simple history, physical, and then depending on, and I know you asked about a risk score, I will calculate the ACC-AHA lifetime risk score, but I also use small, sort of subtle indicators of higher risk features, which are, like I pointed out in my case, family history of heart disease, family history of diabetes, family history of any stroke. So people are poo-pooing the fact that these all, sort of have a common lineage to them. So I'll definitely start with a standard ACC-AHA algorithm, and then I will move into a screening CT or a screening imaging exam. I will move usually to a coronary CAC score, so I'll get an Agatston CAC score, and I will take that Agatston CAC score, and if it's 0, actually we'll tell the patient you don't have any evidence of advanced atherosclerosis, and if you feel like this is enough information for you and for me, which I feel it's okay, I would leave them be and not start any other further therapy. I also would offer the patient, if they had a different disease, let's say an inflammatory disease or something else, I would offer them a coronary CTA. And the reason is that there's about, and I put this in one of the chat questions before, there's about a 15% risk of having luminography defects despite having a normal calcium score. So I do believe very strongly, Habib, in image-guided therapy and image-guided decision-making. And so that piece of the image-guided really is very new. In the last maybe 8 or 9 years, people have said that if you're going to start, therapy, maybe you should know what you're dealing with. And then the final piece is I have very close follow-up with dietitian and exercise lifestyle folks. So I do believe in wellness. Work out of the Massachusetts General Hospital recently showed causality between stress and cardiovascular events through the amygdala hyperactivation. I didn't get a chance to go over that with you, but I would also focus on wellness and making sure that the patient has an idea of how to reduce these risks. But really it comes down to H&P, labs, CCTA, and then my plan includes wellness as well as, sort of diffuse preventive cardiology strategies.
Fantastic. Well, Nehal, I'm going to ask you one last question, and that is, fast forward to 2032, okay? So because you're helping lead some of the research, some of the imaging, some of the phenotyping, some of the biomarker analysis, also there's a lot of work being done with precision medicine and genomics, right? And the question is even though the SNPs and the other existing genotype analyses probably aren't ready for prime time, I want you to fast forward for our audience to 2032, and that same patient, middle-aged, metabolic syndrome phenotype presents to you. In addition to what you described today, what sort of imaging do you do? Plaque phenotyping? Do you do flow analysis? What sort of biomic testing would we be doing? Would we be doing whole genome sequencing for patients at that point? Would we be doing specific metabolic or inflammatory biomarker testing? Where would we be then?
10 years from now, the patients will all walk in, get a single drop of blood. They will have an inflammatory lipid and metabolic panel run, which we do on all our patients anyway already. That will include a glucose. It will include a glyc-A. It will include maybe a CRP if it's still accurate in sort of sensitivity dynamic range markers for inflamed populations. And I think the patient will get some sort of a whole body imaging test where They will be able to very quickly identify sources of high immune activity. So not a PET CT, but something similar. It could be a whole body scan looking for uptake. Why am I saying a whole body? So we're also finding, Habib, that bone marrow proliferation and uptake are related to progression of atherosclerosis. And that's related to stress. So your body thinks stress, it goes to the bone marrow, it dumps out immune cells. So if you have a whole body image that allows us to get all of these pathways at once, it'll be 2032, single drop of blood, whole body image. And the best part is the patient will leave with a therapy that impacts inflammation as well as metabolic dysfunction and dyslipidemia. And I'm thinking that every patient will likely be on some sort of an SGLT2 inhibitor. I do believe that most people will be on some sort of colchicine or some sort of an anti-inflammatory, maybe turmeric if you believe in alternative therapies. And then I think that blood pressure will be taken seriously. Right now, we don't spend enough time taking blood pressure seriously. So I do think that in 2032, we'll have guidelines that say your LDL should be in your 70s your whole life, your blood pressure should be in the 120s your whole life, and I believe that you're going to need some addressing of your inflammatory metabolic dysfunction. We all get it. All humans by the age of 80 will have inflammatory metabolic dysfunction. They call it inflammaging, but we just need to short circuit it.
Wonderful. Well, listen, that was absolutely outstanding. I want to thank you so much for enlightening us here at the Georgia Heart Institute, and I look forward to our ongoing collaborations and getting you down here in person to Gainesville, Georgia. So thanks again for your time, and we really enjoyed it.